بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد آخر الأنبياء وأكرم المرسلين. I'd like to welcome all of you coming after lunch or sometimes without lunch, coming for the third session of the 6th Saudi Hypertension Management Society Congress. We appreciate the active participation of all of you, and we are very happy with the speakers. I mean, we are happy that we have international speakers. They are participating in our meeting from Turkey, from Lebanon, from Italy, from multiple places. So we'll be starting, we don't want to have more delay. We'll be starting the third session today, and I'll be chairing the session, and Professor Roberto Ferrari will be the co-chairman of the third session of the Congress. We'll have the first presentation of this third session by Dr. Tawfik Al-Bassam. Dr. Tawfik Al-Bassam, he's consultant internist and he's expert in hypertension. And he's one of the active members of SHMS group, and he's member of the board of SHMS. He will be talking about very important subject, which is resistant hypertension, how to diagnose, how to manage. He will be presenting by 20 minutes, and after that, we'll go to the second speaker. The discussion will be at the end of all the presentations. Dr. Tawfik, thank you.
Yeah, Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Walid, for this organization and for inviting me. I know we are a little bit late, but what will I do? I'll go fast on certain points, and I will slow down important points. This is my disclosure, and this is the objective of my presentation. I review the different terminology, mechanism involved in resistant hypertension, patient evaluation, treatment resistant, and knowledge gaps, and future research. Now, definition. We all started in JNC 2003, where they had this definition: optimal doses of 3 or more anti-hypertensive medication, including diuretic. The AHA 2008 had their statement almost similar. Then we had a modified definition according to 2017 hypertension guideline, the Americans, where they suggested that the office blood pressure above goal, sorry, Thank you. So this is the modified definition according to the new guidelines. They stated that the office is at least 130 or 80 or more, 3 or more drugs. Then they said we should exclude white coat effect. They need to exclude non-adherence. And they also defined somebody who's at goal with 4 drugs as being resistant. Now, we had also the AHA scientific statement 2018, where it said that above goal, despite the current use of 3 antihypertensive drugs, including RAS blockade, diuretics, CCB, at maximum tolerated doses, and those achieve target on more than 3 antihypertensive medication. They had to exclude non-adherence and exclude the non-white coat effect. Now, the European definition, they kept it more or less the same target, less than 140/90. Again, they stressed the importance of appropriate lifestyle measures and medications of 3 or more, including these medication. It should be confirmed by out of the office. Adherence medication is confirmed, exclude soda resistance, and exclude secondary causes. Then we came up to a definition called refractory hypertension. Again, this definition has evolved first it was used interchangeably with resistant hypertension. Then they said it is a failure to achieve blood pressure goal despite maximal antihypertensive therapy. And then they added a statement, it's failure to achieve goal with a treatment prescribed by hypertension expert at a minimum 3 follow-up visits during 6-month care. They are telling us that this refractory hypertensive patient is a more advanced case of resistant hypertension. It has to be more to acquire this definition. Then we are using ambulatory blood pressure nowadays, and we are having these terms: uncontrolled resistant hypertension, controlled resistant hypertension, white coat hypertension, and masked resistant hypertension. Prevalence, probably from 8 to 12 in the primary care, probably about 11-21% specialized referral center. The prevalence expected to increase after the new guidelines, and the prevalence of refractory hypertension is about 3%. So it's always refractory hypertension less prevalent than resistant hypertension. This is the unhinged resistant hypertension. Again, the prevalence rate compared goes with about 10%. Now, the mechanism, again, the exact mechanism we still do not know. However, we do know there is volume overload, enhanced sympathetic activity, increased RAS, arterial stiffness, endothelial dysfunction, and now there is emerging factors such as microbiota, air pollution, and sleep disturbance. When I talk about sleep disturbance, it's not obstructive sleep apnea, it is something else. Whether you're having too much sleep, too little sleep, or insomnia, both probably they make your blood pressure resistant. Now, what is the implication? The high risk of morbidity and mortality, and higher risk of medication adverse effect. Now, there are certain clues in patients which suggest that patient has resistant hypertension. They are high baseline blood pressure, African American race, obesity, diabetes, elderly, and these are the rest. All these give us a clue that this kind of hypertension patient may be having a resistant hypertension. Diagnosis, again, simply stated, we start with the history, we start with the lifestyle status, the diet, interfering substance, sleep quality. We need to confirm it by out of the office. Examination, focus on target organ damage, secondary causes. If you examine a patient supposed to be resistant hypertension, and there are no target organ damage, probably the diagnosis is wrong. So keep this in mind, the association between target organ damage and resistant hypertension. We need to also assess for secondary causes, confirm adherence to medication, exclude pseudo-resistant. By the term pseudo-resistant is a wide term, includes a lot of statements, a lot of this. These are what we'll talk about, which I'll come to these later. There are certain drugs which induce hypertension and probably makes the blood pressure uncontrolled. These are the drugs we should be aware of. Many of them are prescribed, and there is also the non-prescribed cocaine and so on. Now, adherence is an important topic in resistant hypertension. We must exclude before we confirm this patient has resistant hypertension. And we have a statistic that up to 40% of the newly diagnosed hypertensive will discontinue their medication during the first year. How do we measure adherence? We have the direct measures and we have the indirect measures. Of course, the direct measures, most of them complicated. They are not available, and they are costly. We cannot use them. The indirect measures, these are the ones, and most of them, they are not good enough to pick up the resistant hypertension patient. How do we improve adherence? Education, teach the patients, simplify medication regimen, utilize fixed dose, used to be terminology which is rare, we don't see. But actually, now the studies suggest that therapeutic inertia is an important cause of resistant hypertension, and the effect of therapeutic inertia, it makes your blood pressure uncontrolled. If we come to secondary causes, we know they play a good part in resistant hypertension. These are the list of the causes. What are the clues for the causes? Age of onset, younger age, elderly, worsening of hypertension, presence of extensive target organ damage, clinical clues, and clues. Treatment modality in resistant hypertension, non-pharmacological intervention. I will not talk about non-pharmacological, it's already covered. Pharmacological therapy. Now here we expect the patient already on 3 drugs, including a RAS blockade, CCB, and so we start from there. What we can do first step, modify the diuretic regimen, intensify the dose of the existing diuretic, switch to chlorthalidone or indamamide, or switch to a loop diuretic. This is important to consider before you starting the next step. This is based on evidence that chlorthalidone is more effective than hydrochlorothiazide in blood pressure reduction. And we have a meta-analysis showing that these thiazide-like diuretics probably have better benefit and protect patients from events. Step 2, we add spironolactone. We all know now spironolactone is a very, very advantageous in this state. We already have the evidence far away, but now we have the trial, Pathway 2 trial, which really confirmed that spironolactone among these drugs is the most one that reduces blood pressure in resistant hypertension. Now, if the patient is allergic or cannot tolerate the side effects of spironolactone, the alternatives, eplerenone or amiloride. If we fail to do that, then we come to the territory where there is no evidence. Actually, we need the experience of the doctors. Beta blocker, the heart rate is more than 70, they will help. Vasodilating beta blockers are advised. Central alpha-2 agonists like clonidine, alpha blockers, doxorubicin, of course the direct vasodilators like hydralazine and minoxidil. They are very, very effective, especially in CKD patients. But they do have their side effects. Now, another point, the single pill combination. This is very helpful here in control of their patient. It's associated with better adherence. Regimen, initial prescription leads to a better blood control. And we have key studies which confirm that. And we have enough data to suggest that the fixed dose combination have been shown to improve adherence. They have advantages, yet they have disadvantages. But if they are available and affordable, I think we should start with them. Now, we expect new drugs in the horizon, including the counter-regularity of the RAS pathway, like ACE2 activators, angiotensin receptor agonists, angiotensin 1-sep analogs, MAS activators. We have the nitrotic peptides, we have the mineralocorticoid receptor, and we have the aldosterone synthase inhibitors, and our donors and vaccine. Now, the vaccines used to be important because we could prevent people from getting to a stage of resistant hypertension. But up to now, most of the trials, the evidence does not prove it yet. Interventional therapy. There will be a time that drug therapy may not be able to achieve lower blood pressure targets. Patient might not be able to take multiple drugs. Thus, we need strategies to reach our blood pressure goal. The most 3 interventional therapy, renal denervation, baroreceptor activating, and central arteriovenous fistula. The first one, I will not talk about it because we're going to have a presentation on this, so I will skip to that. It's just point that it used to be the most studied procedure, but we had a problem in one of the trials, which almost stopped everything. We are having a new generation of trials, which is probably going to come back again. The baroreceptor activation therapy, this is based on implantation of electrical stimulator to activate the baroreceptors. We have the carotid sinus stimulation, and we have two evidence, Rios pivotal trial. What they do, they implant two electrodes along the baroreceptors, and they have here a generator, and they try to activate the baroreceptors. When doing that, the blood pressure will get lowered. This is the trial what they tried, and this is the result. In the first 6 months, the people who did not use this receptor activation did not get your blood pressure reduction. After 6 months, all the groups did that. Again, same value. Then it was modified. Instead of having two electrodes, we went for one electrode, smaller device. And again, that was effective. But it has its disadvantages. It is still invasive, costly. It has its side effects, and probably need a battery replacement every 4 and 5 months. Then they came up with a new way, the so-called endovascular Baroreflex amplification. What they did actually is they placed internal carotid artery, specially developed delivery catheter. It is where the baroreceptor are there. And I don't have, really doesn't work, but this is on the right side. It is inserted in the area of the baroreceptors, and did prove that systolic and diastolic blood pressure go down. Finally, we have the so-called central arteriovenous anastomosis. What they did is they had sort of a connected by a Rox-Cobbler fistula between the iliac artery and the iliac vein. In doing so, they relieve the high pressure circulatory part to the venous side. That means they decrease blood pressure. And this is a sketch of how they did it. And this is the way they lowered blood pressure. They have other effects: increased cardiac output, increased arterial pressure, increased compliance. And the trial was small, but it did show a benefit. I'm going fast because of time-wise. This is my last slide. Still research challenges and need. The pathophysiology of resistant hypertension is not clear. The genetic basis of resistant hypertension to be uncovered. We still don't know a lot. Environmental influences. Does air pollution, microbiota, really affect hypertension? We need to identify adherence, and we need to overcome adherence. And finally, what is the optimal target in resistant hypertension? We don't know. There is no study which tells us what is the target we should. We have plenty of data or knowledge we need to fill. This is my last slide. Thank you for listening.